Brilliant. So I just want to, first of all, say thank you very much for this invitation. It's something that I've wanted to do for a long time, which is that I wanted to talk to people who are working in international relations. And I'm sorry if I offended anyone by saying that. I don't know if any other disciplines are involved, but in people in international relations, and particularly people working in global health and international relations, I've been avoiding it for a long time. But so this is a really great, instead of having to force my way in to actually get an invitation to talk about ethics, is something that I'm really grateful for. I want to start off by saying that I actually started off in international relations. My undergraduate degree was international relations, and my dissertation from undergraduate was on HIV/AIDS and international relations and looking at different kinds of negotiating theory and all this stuff. And it's a remarkable different world now than it was in the mid-90s, where it was sort of a very embarrassing thing for a dissertation to be titled HIV/AIDS and international relations. And so it's sort of really interesting to see what happens. Or maybe it's just if you let time go by, you'll end up in the same place. So I'm quite excited and happy to be here. So one of the apologies that I have to make is that if you actually, I don't know if you got the same email that I did, but I got an email that basically said, it's a very low risk audience. You don't really have to prepare a paper, which is obviously not true.
I think we're very friendly.
So I took that as a word, so it is not a formal paper per se, but it's a paper that has been on the outline on my computer for a long time, for about a year. And I'll tell you what it's meant for, and I would like your help in trying to figure out how to present it. So I was invited to write an essay for The Lancet about 8 or 9 months ago on global health justice. And as many of you probably know or don't know, is that publishing in The Lancet is horrendously difficult. And it's a pain in the ass if you do it straight. The best way is to get an invitation, which this was. And I still have been sitting on it because there's something that I want to say, which is I just don't know how to quite say it yet. And so this is one of the trial runs of what I want to say. So the general idea is that this concept of global health governance, and the specific topic of global health security is used, and as you rightly said, a lot of philosophers might say that it's a fairly vague term, and vague terms that people use in a variety of different ways. But not only do they use it in a variety of different ways, they infuse it with a variety of different wish lists that they want it to be. And this wish list sometimes is helpful and sometimes it's harmful. But no one actually says that out loud. And so the question is, can a philosopher take that on as saying, as someone who's interested in concepts, and can sort of actually talk about the concepts of governance, security, and global health. And so I'm trying to figure out how to do things nicely without offending anyone or sort of calling anyone out, which you'll see is very obvious as to what I'm doing and why, who these people are. So I want to start with a story, and maybe this is sort of a gentle way of introducing the topic, which is that Mark Graham is an academic at Oxford. I don't know if any of you know him. I don't know what he is, but he studies the internet and the development of the internet and inequalities in the world and the development of the web and the internet resources are going on. And he gave a lovely talk, and he was sort of put on the BBC a few weeks ago, where he's talking about how the internet is developing, and on the one hand you have the story about everybody becoming more connected, information is being sort of more accessible, and the world is becoming more equitable as a result. And he actually said, well, there's actually other things going on as well, which is that actually you would not be incorrect to believe that somehow everybody in the world speaks English, which is exactly what the internet seems to give the impression that most of the internet is in English. And the second thing is that there seems to be a lot of stuff about certain places and not very much about other places. So for example, there's more articles about Antarctica than there is about Africa. And there's very few people living there. And most of the information, say for example, he takes the situation of Wikipedia, which is supposed to be this sort of free source of accurate information that sort of what do you call it, crowdsourced, and people who are sort of well versed and it's sort of checked and double checked. But it turns out that there's a certain group of people who keep writing Wikipedia entries, and so it reflects a certain group and certain ethics and ideas. So he gives this example of a story of a biography of a man where the story somehow describes the fact that this man's wife gave birth to 15 children without ever mentioning the wife's name. So it's sort of that's kind of the perspective that it gives. But even more, he talks of one particular example is that he talks about giving a workshop in Egypt where there's an Egyptian man who's actually trying to participate as a Wikipedia editor. And so he's looking out the window and there's this obelisk sitting outside the window and he wants to describe this location. It's like this obelisk is here, it's this tall, it's this place and stuff. And what happens after he writes this entry is that there's someone in the United States who decides that this is incorrect and starts editing the Wikipedia entry and says basically, oh no, this is incorrect because this is the correct location and this stuff. And the Egyptian man is essentially saying, no, I'm looking at my window, this is where it is. But the man in the United States had a book that he could provide as a reference. And the book was wrong, but essentially because he had this reference in the book, he was sort of ruled as being correct, while the man who's looking at the obelisk in Egypt is considered to be wrong because he doesn't have anything but his own testimony and sort of stuff. And so the argument is that we need to understand what's going on, and there is also a lot of lessons to what's going on. And so the lessons that I wanted to pull out of this particular story and Mark Rams's thing is that one is that we need to understand that inequality has a great role to play in a variety of things to do, not only in terms of this internet, but what we similarly apply these same rhetoric to global health, right? Everything's going better in global health, we're spending more, doing more, people are getting better, but there's something else going on as well, and we need to look a little bit closer in terms of inequality. But then there's also this other idea of the ethics of what we're doing and the conceptual sort of frameworks that we're using. And so even within this idea of Wikipedia, which is sort of a good, common, shared goal that everybody has, there is great sort of violence that can happen within these two people who are trying to strive for the same thing. That we need to think about kind of the morality or the ethics of individuals in relation to each other within a shared goal. So in terms of global health, right? Global health comes in the same way of saving puppies or something like that. Everybody's fair. But very little disagreement actually comes out in the open about what one person is doing versus another person is doing, and it's really hard to talk about it. So how can we bring this out in terms of the concepts that we're using in global health, in terms of who's doing what and what's going on? And so one of the things that what I want to do is look at the concept of global health governance and sort of seeing what people identify as global health governance, but also the identification of the three major problems of global health as someone has identified. And one of the problems is sovereignty is the number one problem. National sovereignty is in the way of global health. Second is that health requires more than health care, and therefore there's an intersectoral problem in coordinating for global health. And the third one is that there's so many actors now beyond the state that it's very hard to hold all these actors accountable for their actions in global health. So these are the three big problems in global health as someone identified. And I don't think that this is particularly accurate and also reflective of, say, the obelisk outside my window kind of perspective. I think that's the basic argument that I want to make, is that there's some other things that are going on. And so the idea of global health security is an interesting one in relation to this whole discussion about global health and global health governance, because it really sort of asks this question from a philosophical perspective: why global health governance? Right? Why are we not only what is global health and what is global health governance, or why global health governance? And I think global health security is a really good beginning answer to that. Is that, well, we want to improve global health governance in order to secure health, that we want to secure people's health, we want to secure national health, which raises the bigger question was, what do we mean by security? What do we mean by stuff? Which I really appreciated in the last presentation, is actually going through that sort of notions of what do we mean by global health and global health security. So in thinking about this question about global health security, there are a number of, it's not something that we have to start from scratch actually. There's a lot of work that's been done. So I don't know if any of you know, about 10 years ago there was a UN Commission on Human Security. And it dealt with a similar kind of question, which is that how do we reconceptualize security or national security or state security in a different way that is much more effective and relevant and goes beyond the issues that we are normally familiar with. And the argument was that we need to come up with something new aside from state security, and that is that we need to define the concept of human security. And it's a shift away from a state-centered approach, which I would think many of you in this room would now say we have to do in a way. It's not only we have to do because it would be a good thing to do, we have to do it because that's just the reality of it, which is that the health of people is now determined beyond, factors beyond the national borders, and therefore we need to understand what these factors are. These are not only infectious agents that come on ships and people, but these are also non-infectious pathways, whether it be through economic pathways or social pathways or other pathways. And so we've got a much more interdependent world than even 10 years ago, and therefore we have to go beyond the state-centered notion of security. But what also is interesting is that the argument was that we need to focus on human security because it's much more effective in promoting security, which is that if you focus only on the state sort of institutions, you're not going to achieve the goals because the actors and the agents that are influencing the security or human security of individuals are way beyond the state sort of institutions, and therefore to be effective you need to focus on all these other factors as well. So human security, and so in the last presentation, I think one of the things that you jumped on, is that you went from that sort of public health security or national state public health security to the individual security. And so we have this missing piece here about what is health security at a state, national state level, and what is it in terms of other kinds of groups that might be available to us, and then also what is it at the individual level? What does that security look like? So ensuring security at these three levels obviously requires different kinds of analysis, and different agents are involved and different concepts are involved. What I would argue is that what we need to be focusing on is individual level security. But how would I conceptualize security is that I would see it in terms of capabilities, what people are capable of doing, and then I will explain why I think this is the right way to go. So I made an argument about sort of a few years ago, it was published in a book. And the reason why I started off with this story about the internet and why I'm sort of interested in that particular story is that when my book was published about 2 years ago, and it was being sort of reviewed in a variety of different sort of journals, one journal which I won't name, I sort of wrote the editor and said, you know, I haven't seen the review of this book yet. I'm just wondering, have you got a copy of the book, or shall I send you a copy? And the response I got back was, oh, you know, we only review books for American audiences. And so it's like, what about my name or my book makes it like it's not meant for an American audience, right? And so it's that kind of sort of dynamic that I'm personally going through in relation to arguments about global health justice that then are directly impacting sort of these debates about global health and global health governance and all that stuff. And so when we talk about global health security, I don't know if so far you have focused on individual level security yet, or whether you've been, as usual, been focusing on that the macho state level kind of security, right? That's the kind where international relations really sort of is about. It's about sort of hanging out with the big guys and the sort of institutions. But my argument is that individual level security or individual level health capabilities will be more efficient for you at that national level, more effective in securing your national level, but it's also the right thing to do. So these are two different lines of arguments, which is that you should focus on securing individual level health capabilities because it's going to be more effective and efficient for you at the national level, but it's also the right thing to do. And I'll show you why in this way. So the way that people have been conceptualizing health, health equality, health equity in sort of political philosophy debates is that you've got a sort of a range of choices. One is that you've got the choice of basically maximizing the preferences for certain health states. So the idea is that in the UK, for example, you have nice and you have qualities. And you might have heard of thresholds for sort of approving or sort of not approving a variety of health interventions. And so this is essentially a measurement that is measuring people's preferences for particular kinds of health states. Do you prefer to have one broken leg more or less than having your toes or not having your toes, right? And so based on these kinds of preference weights, and they have 5 different sort of ideas of what you are physically able to be and do, or just physically do, and then you give preferences for it, and different kinds of health states are given these weights. And so then they sort of quantified in terms of pounds how much a particular intervention will cost in order for you to achieve these kinds of things. And so this is preferences. These are people's preferences for certain kinds of health states. And so you have a limited health budget, and what you're going to try to do is maximize the preference for health states based on your sort of limited health budget. This is the way that, this is the prevailing way that we do it. Now, in sort of developing countries, there's something called the disability adjusted life year, which is that you take sort of variety, what you're basically doing is taking the number of life years lost to illnesses or disease, and then you're also taking the amount of time that's lost because you're impaired in some way. So a disease keeps you alive, but you're less able to do something, or less able to do your life, and so you quantify that into time lost as well. So a disease gives you both the life years that you're lost, but also the time that you're impaired from fully being able to do what you want to do. That's a DALY. And what you want to do is that you want to maximize the number of DALYs removed from a certain population. And that is also based on certain kinds of preferences, because you give preference weights to which year, during a life course, which years are worth more than other years. Recently, I think they've taken away this preference weights because it's very controversial. The idea was that people who are in their working age life were given more weight than people on either side. So if you die, if you had a disease that was affecting an infant versus someone who was working in a working age population, the priority would go to someone who was working age population. So as you can see in both of these situations, it's a standard utilitarian philosophy, where you're basically saying there's one outcome that we're interested in. We're interested in bodily functioning or preferences of bodily functioning. We're going to maximize that, and we're going to sort of do whatever that does. And so this has been the prevailing way that we think about promoting health in a population, and also in a way, I guess, implicitly the security of a population is that we're going to, this is the way that we're going to do it. So another sort of approach has been this idea that preferences are not the right way to go because they're malleable. People get used to their situations, people get used to deprivations, or people get very spoiled and get used to lots of luxurious items. And therefore we should actually have some sort of objective view about what we should be distributing to people in a good society. And therefore this other way of thinking about it is that somehow we should be giving people access to health care based on their equality of opportunity to live a certain kind of life as members of their society. And therefore health care is actually sort of providing equality of opportunity just like education does, and just like other policies do. and therefore we want to provide stuff. And so security in that sense is that this society will provide you with healthcare, that it will secure you your equality of opportunity to the greatest extent possible, not beyond, not below, that sort of stuff. And so the problem with this idea is that so this question of what is the health that is actually being promoted, right? And so one of the issues is that this idea is that health is statistical normality. So in a given population, whatever is the biologically, statistically normal functioning becomes health. And so we will provide healthcare in order to make you biologically sort of normal or statistically normal in what's going on. And so, and it's also bounded within a particular society. So if one society has got lower sort of statistical functioning, that is your claim. Your claim is to within that stuff. While another one, if it's a higher, it's another stuff. And then also this idea about whether you have any obligations to address the health of people outside of the society is very few, because your ethics and your justice is very much within a society. And so there's many other options. And I won't go into it, but so if we have the utilitarian and we have basically this Rawlsian concept of resources that's going on, this third school is this idea of capabilities, which is that if you give people a certain good, so for example, healthcare, right, and individuals are inherently diverse in a variety of different ways over life's growth. But so if you give everybody the same kind of good, you're actually going to create inequalities in what they're able to be. So for example, if I'm a pregnant woman and you give me a kilo of rice, and I'm a young boy and you give me a kilo of rice, and I'm an old woman and you give me a kilo of rice, it's the same, equality is the same, but I'm going to end up being able to do less or more because inherently I'm diverse. So what we care about is not that people get equal kilos of rice, but actually we get equal opportunity and are able to equally do what we want to do. So that's the idea of a capability, that capability to be and do things in life. And so that's where equality should be focused on, not on the kilo of rice, but on this equality of being able to be and do. So then there's this question about which capabilities are we talking about? Which capabilities should we be focusing on? And so there's different kinds of arguments about that. And one sort of set of basic capabilities has been developed by a woman called Martha Nussbaum. And she's basically said, if we think about a human life with dignity, and we think about what kinds of things that they are able to be and do, we come up with some basic things. One is that they are alive rather than dead. So that's sort of one sort of important thing. And then they are sort of free of impairments and free of restrictions, of bodily restrictions. They're able to sort of engage with other human beings. They're able to have capacity for rational thought and to be able to learn and to do a variety of other things. And so then she has this sort of list of 10 basic capabilities. So in my argument for health justice, what I say is that the right way to think about health and health capabilities, to think about these 10 capabilities as a cluster. Because in reality, for us to be healthy is not just a single thing, it's to be able to do lots of different kinds of things. And so to think about health as a cluster or a meta-capability of doing these basic things, it's a minimum threshold of well-being. So it's sort of like a conception of a minimally decent life. And this is what I say is a capability to be healthy. So why is this capability to be healthy argument at all interesting or important, aside from just this conception of health, is that it's supposed to provide the conceptual coherence for a human right to health, and it's supposed to be providing the justification for a human right to health. So the argument is that human rights have no justification, right? So this is one of the sort of standard things. It's like, there are a list of things that people wrote down on a piece of paper. There's no theory that sort of is grounding it, and so without a theory, they're philosophically kind of incoherent. And so people were saying, well, let's just make it into a minimum package of healthcare, and so let's not worry about health, and what is health anyway? It's not this fully flourishing thing, and so there are lots of sort of competition, sort of arguments against it. And so this idea of a capability to be healthy is this idea that we should be sort of making that into a moral right of every human being. And the justification is that this health is sort of a set of freedoms, or a certain kind of freedom. It's a freedom if we are sort of something that we value as sort of a rock bottom value in societies across the human species, then health will be a central expression of that kind of value of freedom. And so I won't go into the philosophical debates about this idea of freedoms and human dignity, but I just want to provide you with the outline of something like that. Now, where this comes into security issues and debates is very interesting. In the last talk we talked about it, which is that it turns out, and this is where Joe Wolf's work comes in, is that Joe Wolf, what he did was that he said, look, these 10 capabilities that Martin Nussbaum talks about, what happens really with these 10 capabilities? And so they did a study where they looked at homeless populations in the UK and Israel, and they asked them, what capabilities do you care about? You know, what makes a good life for you? And over and over and over again, and this is true of everything else, health always comes important. People always worry about their biological sort of functioning, the pain that they feel in pregnancy. But what also that comes about, which Martin Nussbaum didn't have, is this idea of insecurity, right? Is that human beings, especially powerless and vulnerable human beings, constantly are insecure. They feel insecure about their physical, not only functioning, but threats to their body, threats to their functioning, and also inability to look beyond the present. Right? And so this idea of a capability to be secure, right, turns out to be very important, and it's come out in sort of other work that I've done as well, which is that I work with what are called problem families in the UK. There's supposedly 1,000 or 100,000 families in the UK that are incredibly resistant to any kind of transformation, and they cost the state £1 million each year, because every time the police get called out, it costs £375, and every time the neighbour calls the police, and so they cost us up. And so in working with these families, one of the first things that we're doing is basically saying, what is a good life for you? What kind of life do you want? What kind of life are you living? What kind of life do you want? And it turns out they're remarkably similar to Martin Nussbaum's 10 basic capabilities. Right? And so one of the things that they say that Martha didn't say is that it would be really great to feel secure. Really great to feel as though our rent and our housing and where we live is going to be someplace that we continue to live. It would be really great to know that we would be healthy in the future as well as today. So this idea of security as let's say a moral value in a life, in a human life, is turning out to be more important than people have given it. And this is this sort of obelisk outside my window problem, right? Is that who's writing what and why are they not missing, and what are they missing, kind of stuff. So this idea of insecurity and security turns out to be very important to people who are actually at the bottom of this story. So health security and sort of and security in general, I think, is very related. So this idea of this cluster of capabilities, I'm not going to say that I have been at the forefront of saying security is really good, but one of the things about this cluster of capabilities and capabilities is this idea that people have a right to it, a moral right to it, which means that the environment, the society, the social institutions have an obligation to ensure that human beings have this basic capability, this health capability, that is, ensure not just today, but consistently to the extent possible, that people live their lives knowing that they are secure in their ability to do. So one of the big examples is I have a completely different outlook on life because I live in the UK, which provides me with health care, than I did 10 years ago when I lived in the USA, where I didn't know whether I was going to have health care yesterday or whether I'll have it tomorrow, and I didn't have it, for a number of years. It's a completely different kind of way of living. That's the kind of thing when I say ensure capabilities, that social institutions ensure capabilities. They provide that sense of security that you can do it. So just sort of an interesting I still got 10 minutes. I'm watching the clock. So I want to also give you some. So I want to do two things before I end. So the other thing that I want you to think about in this sort of individual level view of these global issues is that many of you probably know about this whole literature on the social determinants of health. These are the non-healthcare determinants of health, illness, and disease. And so there's lots of different kinds of pathways that's happening. But one of the interesting things that has been underexplored is this idea of time orientation, right? So many of you probably have seen these ads or these studies where you put a little cookie in front of a child and you say, if you wait 2 minutes, I'll give you 2. And then you go out of the room to see what the child does. But that's really funny and odd to watch. But it turns out that people have tracked these children over time. The people who waited to get the 2 cookies always do better in life than the person who eats the cookie, right? So there is very much something going on here about time orientation, whether you're present orientated or future orientated. And it's no surprise to lots of people, which is that this present orientation and future orientation is on a social gradient. So that means that the lower you go down the social hierarchy, the more you're going to become present orientated. And present orientated because you don't know what's going to happen tomorrow. Right? And so there's a question here about security in terms of that idea to be able to project, to be able to aspire, to be able to make plans about your future. And that actually is sort of somehow a vicious cycle where if you don't have that kind of secure notion or the feeling of security or understanding of security, you're actually digging yourself into a hole by living in the present, as opposed to other people who are able to have that sense of future orientation, and therefore they're able to build that. So security becomes important in other ways as well in terms of health security, because people who are present orientated tend to have worse health than the people who are future orientated. And it might just be that whether sort of what's really doing the work on a daily basis about whether how you walk across the street, what you eat for lunch, is more about your time orientation and feelings of sort of security than it is about your virtues of being responsible or irresponsible, or whether you are sort of a hedonist or something like that. So what does this have to do with this macho world of global security and global health security and state and other stuff? Is that there's two things that justify any public policy in the present world. One is that all you have to do is say it's good for national security, and two is that it's good for economic growth. So those are the two things that you can possibly say that will sort of give you free rein, which is I think what you were saying about just securitize it and you'll get more resources and people will walk away from you kind of thing. So that might be true. So if you want to, so there is an argument that came out in the Human Security Commission, which is that there is a strong relationship, in which you don't see that in this whole global governance thing, is that people talk about global governance for health without talking about the fact that most people in the world who are suffering ill health are either poor or because of conflict. And there's very little talk about conflict and wars in the global health governance discussion. It's sort of that whole normalization. Let's talk about the non-chronic diseases and the infectious diseases, but we're just going to not talk about the fact that there's lots of hundreds of thousands and millions of people dying because of conflict and deprivation and all these kinds of other things. Security has the possibility of bringing those two things together. So when we talk about global health security, it's to be able to talk about the health impacts of conflict and the health sort of threats from poverty, deprivation, and globalization, whatever you want to talk about. And that would be one significant sort of addition to this whole conversation, is that these people who sort of want to talk about global health governance or global governance for health without actually talking, it's sort of a bit like in the mid-90s when bioethicists were talking about health and ethics without ever talking about the hundreds of thousands of people that were dying of AIDS, right? So it's sort of that kind of conversation that's happening now in terms of global health governance and actually where are people dying and what are the sort of health impacts and where are the health issues something like that. So security does that, and if you want to improve human security, what we do know from an empirical standpoint is that vertical health programs do not provide health security. Right? So these sort of donor-driven, specific illness disease programs are not sustainable, are not sort of going to provide population health, are not going to ensure that at a state level that health is actually promoted. They might sort of help particular individuals in particular places during a particular period of time, but you sort of address the malaria, but then you have famine problems, or you address HIV/AIDS, but they're still starving for some other reason or something like that. So there is this question that if you look broader than that disease focus, we need to sort of be thinking about health broader than that disease focus. So where should we look to? Well, there's this thing called the capabilities approach, where you look at sort of the idea that enhancing people's capabilities across a different sort of thing. The second sort of point about the capabilities approach and this improving security or health security through that is that the concept of a capability is that my capability to be healthy is not simply a biological internal faculty. It's actually determined by factors both internal and external to me. So from a very sort of basic sense, which is that in order for me to walk out at this door, it's not just an internal concept, it's not internal factors, it also means that the environment outside has also to be supportive of that for me to be able to do. So to be healthy is sort of a similar kind of concept, is that it's not only just my internal biological function, but the environment has to be supportive in a variety of different ways. The physical environment has to be supportive, as well as the social environment has to be supportive. So if I'm a woman and I am sort of need variety of access to information, healthcare, whatever, I need to be able to live in an environment where I'm allowed to walk outside my house, I'm allowed to access information about reproductive health, I'm sort of taken to the clinic when I sort of need to give a sort of a childbirth. If those external social environments are not there, then I'm not going to be able to promote my health, protect my health, maintain my health. So the concept of a capability encapsulates both those internal and external factors. So if we are to promote health security at that sort of population level, it entails addressing those social factors, not just sort of those internal biological behavior factors. And then the argument is that when you